function off. Questions will be taken at the end of the presentation. So any comments or questions that you have for Dr. Desai, please put that in the chat box and we'll address at the end of the session. Also at the end of the session, a group photo will be taken and that will be by screenshot. So if you wish to participate, please ensure that your video function is on. Please do not take any photos or screenshots of the slide. So Dr. Desai is a diplomat of the American Board of Dermatology and a board-certified dermatologist. He graduated with honors from Emory University and received his medical training at Morehouse School of Medicine in Atlanta, Georgia. Following medical school, Dr. Desai completed his medical internship in internal medicine, and he completed his residency at the University of Alabama in Birmingham. Dr. Desai has been active on a local, state, and national level with numerous medical organizations. His major accomplishments have been with the American Academy of Dermatology and the American Medical Association, where he has held numerous elected and appointed positions. He is also actively involved in teaching and mentoring medical students and residents. He is the founder and medical director of Innovative Dermatology, a state-of-the-art dermatology practice, and also serves as clinical assistant professor of dermatology at the University of Texas Southwestern Medical Center. Dr. Desai is the author of numerous publications and has been invited to present at numerous international dermatology events. He is a world-renowned expert in the field of skin of color, pigmentary disorders, atopic dermatitis, psoriasis, acne, and cosmeceuticals. Dr. Desai also conducts numerous clinical research trials in his private practice. Dr. Desai is very active in the local and national dermatologic community and was elected to the AAD Board of Directors in 2017. In his role on the board, he represents the interests of over 20,000 dermatologists worldwide and also serves as an elected member of the AAD Executive Committee. Dr. Desai is also the immediate past president of the Skin of Color Society, which is the largest international organization dedicated to the field of skin of color dermatology. And he is also past president of the Texas Dermatologic Society and the past president of the Dallas-Fort Worth Dermatologic Society. He also served on the board of directors of the Skin Pact and is the past immediate chair of the AAD Leadership Development Steering Committee. He also serves on the board of directors of the Women's Dermatologic Society. In 2017, Dr. Desai was also appointed to the United States Food and Drug Administration Pharmacy Compounding Advisory Committee, and he was the only dermatologist to be on that important committee. He also serves as the associate editor of the Journal of Clinical and Aesthetic Dermatology and Pigment International, while also serving on numerous editorial advisory boards. Dr. Desai is a sought-after media spokesperson in the area of skin of color and advocacy. And frequently he speaks at congresses and presses around the world. Dr. Desai is married with 2 children and resides in Dallas, Texas, and we look forward to having you today. Without further ado, Dr. Desai.
Well, Crystal, thank you so much. You're so kind to give such a warm introduction, and a special thanks to you and the planning committee for all of your hard work in putting this together. And I would be remiss without saying a special hello and thank you to my dear friends, Dr. Esther Freeman, and also I see Professor Nkosi Delova tuning in from South Africa. So all of you, I know many of you, and it's really an honor to be with you this Sunday. And it's great to see everyone tuning in from so many parts of the world. So looking forward to this talk. I hope you have questions ready. Feel free at the end, we'll hopefully have some time for a robust Q&A, and I hope this will be helpful. So I'm going to share my screen and we will get started with the slides. Hopefully you can see that. Perfect. Hopefully you can see the slides now, and we will get started. Once again, it's my honor and pleasure to present in front of Glowderm today. And treating and diagnosing and managing pigmentary disorders, I think, is an issue that can be both gratifying, complex, and perplexing for all of us. And I really thought this title of the talk would be the most appropriate for all of you around the world, many of you who are treating majority skin of color populations, treating patients from a variety of backgrounds, both racial and ethnic, and probably have even better insights into some of these things than many of us here in the US do. So I think this will be hopefully a really dynamic dialogue that we'll be able to have together. If you have any questions during the talk that you don't want to ask now, please feel free to reach out via email or on social media. I try to post things related to skin of color and pigmentary disorders on Twitter at Seemal Desai, MD. These are my disclosures. As was mentioned during my introduction, I do perform clinical research and consulting in pigmentary diseases, particularly vitiligo and melasma, but I also do some work in newer sunscreens and cosmeceutical products for patients of color. So I do want to disclose that. I will be discussing off-label indications today. Much of what I'm talking about and much of what we use for treatment in our therapeutic armamentarium in pigmentary disorders, you probably all know as FDA off-label. And I do have to disclose I serve on the US FDA. However, my federal role will not interfere with today's talk. So I thought we'd begin the discussion, and I would show you this picture of a really fascinating article that was published on the front page of the BBC's website a few years ago. And I thought that this theme is something that we all, as clinicians, as skin of color experts, as residents in training in many parts of the world where you are seeing these issues, need to keep in mind when treating pigmentary disorders. And that is the concept of patients tying in their own skin color, not only to their own identity, but also to how they feel about their skin color related to where they fit into their social structure, in their own society, and in their background. And what do I mean by that? Well, I think all of you would agree that in many parts of the world, the color of your skin, not just what ethnic background you are, but even within your ethnic group, the darkness of your skin is oftentimes associated with where you fall in to social structure, to how you're viewed in society, and oftentimes ties into more serious consequences that have psychological impact. And so when treating patients with pigmentary disorders, particularly with skin of color, I think keeping in mind that when patients come to us to get their melasma better or treat their post-inflammatory hyperpigmentation, to that patient, it's not just treating a pigmentary skin disease. To that patient, that color is now part of their identity. And many patients tie in these pigmentary disorders into what they feel about themselves. And I think that this social media campaign that was launched a few years ago that really took off for a while and then it sort of waned in its popularity was called #UnfairAndLovely. And it was a social media campaign to celebrate darker skin types and celebrate one's own skin identity related to their own natural pigment skin tone. Because we know that the increasing incidence of colorism and widely held beliefs in many parts of the world related to the fact that, quote, fair skin is more attractive is something that is very, very detrimental to both the psychological and social constructs in many parts of the world. And I think that has become exceedingly evident since the pandemic started last year, and we saw so many both US-based and global social injustices related to communities of color. And so keep in mind that when treating pigmentary disorders, try to take a step back and really get a sense of how is this disorder affecting the patient's overall sense of their identity. And I think by doing that, we set ourselves up to really evaluate what the patient is dealing with and suffering from more broadly. So let's start our discussion about pigmentary diseases today, and let's focus a little bit on melasma. And before we talk about treatment, I I want to show you this clinical picture. And I think for residents in particular, I wanted to show you this image. This is obviously a female who has melasma. Well, why do you know that? You know that because this patient has the pigmentation that looks sort of tan, brown, hypermelanotic on the cheeks. You can also see the upper part of her lip and the chin, all classic areas for melasma. And notice also sparing of the nasolabial fold. Now, if you look very closely at the circled area in the yellow circle, that is another physical finding clue that is very specific for melasma. Now, why am I making a big deal about this? The reason is because sometimes, even myself as a pigment expert, we get caught in a trap where we think that every patient who has facial hyperpigmentation has melasma. You know, a patient comes into my clinic, complains of dark spots on the face, I'm getting brown patches. My mind immediately thinks, oh, you might have melasma. Let's start thinking about how to get your melasma better. But we need to remember that not every form of facial hyperpigmentation is melasma. So how do you, in a very quick physical exam, differentiate melasma from other forms of facial hypermelanosis? Well, one of the easiest and most specific ways to do that is by looking at the area that I've circled. Within the patch of melasma on the cheeks, if you notice the patient's own normal skin tone coming through that patch, that is something that I've coined the term called the peaking sign. So if you see the patient's own normal skin tone peeking through the brown pigment, that is melasma. And that doesn't usually happen in other forms of facial hyperpigmentation. So remember, melasma tends to be symmetric. It tends to start on the cheeks where it's its most commonplace. Then it can involve the upper lips. It typically spares the nasolabial fold. And if you see the patient's own normal skin within the patch of hyperpigmentation, then yes, you're dealing with melasma. And now in probably 15 seconds, you've examined that patient and you can pick up on all these clues. What are some other ways that you can differentiate melasma from other facial conditions of hyperpigmentation? The other very specific clue is that melasma tends to be very respectful of facial bony contours. So it's very rare that you're going to have a melasma patient who has hyperpigmentation on the cheeks, it spares the fold, but that it also extends into the periorbital area. In general, melasma tracks along the upper zygomatic arch. It does not enter into the periorbital area. So we have a condition now that is very respectful of bony facial contours. Now I've given you this clue about the peaking sign, and you know it spares the nasolabial fold. That's how you're immediately going to say it's melasma and not something else. So what else could it be if it's not melasma? Well, one of the most common things in patients of color that gets confused with melasma is facial acanthosis nigricans. Remember, facial acanthosis nigricans can look very similar to melasma, except there's two key differences. One being that it does not extend medially into the medial part of the malar cheek. Facial acanthosis nigricans is also symmetric. It's also brown. It's also hyperpigmented, but it tends to be more lateral and preauricular. Whereas remember, melasma, I told you, is more medial with the peaking sign respecting the facial bony contours. There's another condition in patients of color that gets oftentimes confused for, is it facial melasma? What else is going on? And that's Lichen planus pigmentosis, which we'll talk about in a few minutes. But Lichen planus pigmentosis also tends to look very similar when it's on the face, except that tends to be more lateral temples and again, preauricular. So now, just in some physical finding distribution clues, you're able to astutely differentiate, okay, yes, it's melasma, no, it's not, and what else could it be? And we'll talk more about this in a minute, but I think those are some helpful clinical pearls that I wanted to give you. Now, when we look at our treatment options for melasma, we have a very large therapeutic armamentarium. Everything from topical retinoids and combination therapy, off-label uses of azelaic acid, kojic acid, cosmeceuticals, sunscreen, and then even chemical peels and laser therapy. But the most important thing that you as residents in training around the world should know is that every melasma patient that comes into your practice should be counseled that melasma is a chronic skin disease, just like if you were to have psoriasis or atopic dermatitis or even have a chronic disease like diabetes or hypertension. Melasma is not curable. It is controllable, and we can help the patients get a better outcome in their visual appearance of the hyperpigmentation, but it is not something that goes away 100% ever. And that's because the pigmentation production in the skin that is usually stimulated by tyrosinase enzyme activity is always running. And what I tell my patients is, think of your skin right now, if you have melasma, as your pigment cells are in overdrive. They're working too fast. The engine of the car is running at the speed of a sports car. It's like a Porsche. And my job as the board certified dermatologist is to give you therapeutic options to make that Porsche engine speed, or that very high engine speed of production, and bring it down to a smaller speed of a non-sports car. And then you maintain that pigment production at the lowest level possible using these tools. And we'll talk about that in just a moment. Now, one of the things that I think is very interesting in the pathogenesis of melasma now is the vascular component of the disease and the metabolic issues associated with melasma. So when I started first getting involved in pigment work during my residency, we were told that yes, it's overproduction of melanin, usually due to tyrosinase enzyme activity, and that you just got a lot of melanin, and that can either be epidermal melasma or dermal melasma or mixed melasma. And all of that is true. But how many times have you treated someone with melasma and the brown gets better, and then you still see some of that pinkish red ruddiness on the cheek after you get the brown better? It almost even resembles erythematotelangiectatic rosacea sometimes. And that's because we think now that as you treat the melanin and you get that better, you're actually unmasking dilated vascular component of the disease, which has been shown immunologically to be related to increased vascular endothelial growth factor. And so the next phase in our therapeutic journey in treating melasma is going to be, how do we target both the pigment and the vascularity? The one other thing I will mention in pathogenesis is that with the vascularity, the other thing that we found in patients with melasma is a very increased density of mast cells in the upper parts of the dermis. And mast cells, we think, play an important role in the reason that over time, when you see pigmentation in the lower layers of the epidermis and why it drops down into the dermis, we think that's due to mast cell degranulation that then degrades the type 4 collagen in the basement membrane, allowing that pigmentation to drop down, which is why when you see a new patient with melasma, you want to treat fairly aggressively to prevent that pigmentation from ending up in the dermis. Now, thyroid disease is the other thing that I want to briefly mention about melasma, which is that we have now studies that have shown that thyroid dysfunction is associated in many patients who have the disease. Now, typically we think of thyroid dysfunction in the world of pigment as being related to vitiligo. But in patients with recalcitrant melasma, I do check thyroid stimulating hormone and free thyroxine levels in patients who are not responding to traditional therapy. So this does not mean that every patient who comes into my practice is told to go get blood work done. But if I have someone who's not improving and their skin disease is not getting better, then yes, I will recommend they check a thyroid level, or at least have that done through a primary care physician, because you may find abnormalities, which is why the disease is not improving. Now let's talk a little bit about therapy. And I want to just briefly point out a couple of comments about hydroquinone. And I will say this from the start, in my opinion, hydroquinone is still the gold standard in topical skin lightening. However, it is studies like this journal that was published in the BJD and many others like this that have shown time and time again that hydroquinone really, as a monotherapy ingredient, is inferior to using hydroquinone in combination with a topical steroid and a retinoid, and called triple combination treatment. In many parts of the world, I know this is referred to as triple cream or combination cream, whatever you want to call it. But the combination of hydroquinone with a retinoid and a steroid is superior in so many studies when you look specifically at the melasma global severity scores and the melasma severity index. And so the message here is that, yes, hydroquinone plays an important role in our therapy. We use it in a systematic fashion but you should really not use it monotherapy unless there is a reason for a contraindication to the retinoid or steroid component. Now, hydroquinone safety is something that I think all of us in dermatology should be aware of. Patients ask about this. I have patients coming in saying, oh, I would never want you to put me on hydroquinone because I saw on Instagram that hydroquinone causes cancer, or that I read an article in the New York Times, or that I heard this. We have to dispel myths about hydroquinone safety. Multiple studies have been done that have shown that hydroquinone is safe and effective when used in a systematic, supervised fashion. There has been no risk of carcinogenicity in human subjects, but it is important to take the time to discuss this long-term with your patient. And if you don't, then you'll end up with something like this. And once you see a case of this once, you will never forget this. And obviously, all of you know what this is. You may have seen this already in your practices and in your training. This is exogenous ochronosis. This happens to be a female patient who was sent to me in consultation by one of our colleagues out of state, Dr. Bonnie Aluski. And this was a patient who had been using 8 to 10% hydroquinone monotherapy for over 10 years and developed exogenous ochronosis. And once you see a case of exogenous ochronosis, you'll never forget it because there is nothing else that looks like this. Classic follicular and perifollicular stippled purple blue pigment, has very clinical diagnostic dermatoscopic findings, and this is almost impossible to eradicate once it happens. So yes, hydroquinone has its limitations, but it still remains the gold standard of treatment in treating pigmentary disorders. So I've told you it's the gold standard, and I've told you to use it in combination with a steroid and a retinoid, but then I've told you that it's got limitations. So how do you use it practically? Well, in my patients with melasma, what I typically do is prescribe a triple combination therapy. I make my own compound that contains 6% hydroquinone, 0.1% dexamethasone, and 0.025% tretinoin. And I have my patients use that for a maximum of 12 to 16 weeks. I get their disease under control. Remember, I told you it's a very fast sports car engine that's making pigment. Use your triple combination to bring that level of pigmentation down. And then I transition my patients to using off-label second-line topicals, such as azelaic acid, which is one of my favorites. I use lots of azelaic acid in my practice to maintain that level of pigment production at a lower speed. Remember, it's a chronic disease. It's never going to be cured. You're just going to have to help the patient maintain it and get it better, which means they always need to be doing something. Of course, the number one thing these patients must do at all times is sunscreen. And by the way, in my patients with skin of color, I prefer using inorganic sunscreens or the physical blockers. I have found that there are subsets of patients, especially melasma patients, remember, who have vascularity and mast cells, have very sensitive skin. You give them a chemical sunscreen, they are prone to irritation. What happens in a patient with skin of color when you get irritation or irritant contact dermatitis? You get PIH, and you don't want to change, create another pigmentary issue when you're trying to get them better. So sunscreen is always a must, and maintaining on some sort of lightening agent long-term, such as azelaic acid, allows us to do this in a very systematic way without having long-term safety issues. And this was a study that was published. I mean, there's numerous studies. Our colleagues in India have done an amazing job of this. I collaborate with them frequently, as well as our colleagues in Singapore and in Korea, who do a lot of pigment work. 20% azelaic acid works very, very nicely to maintain the level of pigment production. And let's say the patient has a flare. If they have a flare, then you rotate them back on to your hydroquinone triple combination therapy for an additional 8 to 12 weeks to calm that engine down. And then you rotate them back off. And doing this rotational algorithm of treatment is really something that I think sets you up for success and reduces the chance of developing ochronosis and long-term toxicity with hydroquinone. Now, oral antioxidants is something new in our treatment armamentarium for melasma. New meaning we've only been doing it for the past few years. That's why I wanted to mention it to you. There is a dietary extract from a fern plant. The fern plant is indigenous to South America, and that plant makes an ingredient called Polypodium leucotomus. Polypodium leucotomus is a natural antioxidant. It is also able to increase the skin's own internal UV protective factor against UV light. And it does not replace sunscreen, but it has been shown in several studies to be helpful as an adjunctive treatment to melasma. So my patients who are here in a hot summer in Dallas, where it's 30, 40 degrees every day, let's say one day they forget to wear their sunscreen, but they remember to take their polypodium leukotomus. Well, at least then they have some UV protection compared to having none at all. So polypodium leukotomus is an oral dietary supplement. Usually 240 milligrams is how it's dosed. And I tell my patients to take one in the morning and one at night, or they have other formulations that are double dose if you have someone who only wants to take one capsule. And I find this to be very helpful in adjunctive additional treatment for melasma. Now, in our last few seconds on melasma, and then before we move into a few other pigmentary diseases, let me briefly talk about tranexamic acid, because everyone wants to know about tranexamic acid. I'd love to hear from the residents on the call during our Q&A if you've used it or what you think about it. But tranexamic acid is a very interesting molecule in our treatment for melasma. Tranexamic acid controls pigment production by a very complex mechanism of action. But the bottom line is it blocks the production of prostaglandins and arachidonic acid. And prostaglandins and arachidonic acid as pro-inflammatory cytokines are the inciting factor in that tyrosinase enzyme activity. They're the fuel for the sports car engine. So you cut off the fuel supply, so you shut down the engine. And that's kind of how I explain this to my patients. It's been used, by the way, for many, many years in the operating room in terms of reducing hemorrhaging. It's also been shown in some studies to help chronic spontaneous idiopathic urticaria. Long story short, it's been very, very helpful in our patients with melasma. It is FDA off-label, and there are some limitations. Oral tranexamic acid can typically be dosed at 250 to 500 milligrams once to twice a day. I typically dose it here in the US as 325 milligrams twice a day. And it's important that patient selection is taken into account. So does every melasma patient in my practice get tranexamic acid? And the answer is no. But this is very helpful for the patient who you've put on the hydroquinone 12 to 16 week. You've rotated them to second line topicals. They're not getting better. Those are the patients who tranexamic acid is helpful for. Now, take a very detailed medical history and make sure these patients have no histories of deep venous thrombosis, spontaneous miscarriages, they're not pregnant, they're not breastfeeding or smoking. Your normal, healthy male or female patient, great candidate for TXA. Any of these issues, you want to avoid it. And there are topical formulations if those of you who are a little bit nervous about using oral tranexamic would like to try. This happens to be a study that we published on the first topical tranexamic acid and kojic acid containing serum that can be used once to twice daily. If you're interested in using topical tranexamic acid, it's typically 3% concentration, and it has also been very helpful in my practice. Now, one other comment about tranexamic acid let me make. When you dose oral tranexamic acid, it works pretty fast. So this is not the type of oral medication that we're going to tell the patient, okay, I'm going to give you a prescription and we're going to give it 9 months, a year to see if it works. No. When oral tranexamic acid works for melasma, it works quickly, meaning that you may see results in as soon as 4 weeks. And usually by the 3-month mark, if it doesn't work or it's not better, the patient's not better on it, there's no point in continuing it, in my opinion. So when it works, oral works pretty quickly. And that's something that I think is very helpful when figuring out how to dose this. Now, let me mention this ingredient as well. This is something called cysteamine. Cysteamine is a naturally synthesized amino acid derivative that's also found in high concentrations in certain dietary sources that has also now been proven to be helpful in our treatment of melasma and post-inflammatory hyperpigmentation. The reason we've never used it in this setting before is because cysteamine is a very smelly ingredient. It smells horrible. And so there's never been a formulation until fairly recently that's aesthetically elegant for patients who will be compliant. This happens to be an example of where it works. So if you look in the upper left-hand corner, you see the tyrosinase enzyme in the melanin pathway. That's where hydroquinone works. That's where azelaic acid works. That's where kojic acid works. But cysteamine also works in a lot of the other steps in melanogenesis, which I think is why it's interesting and we're learning more about it. But again, I'm telling you these newer things because we're shifting away from hydroquinone, even though it's still our gold standard, and we're moving into the next phases in our melasma journey. And this happens to be some before and afters of a patient who had been using only monotherapy cysteamine for their melasma. Again, does everyone see in picture C how the brown is better? But it goes back to what we talked about, where you see that redness and that little bit of that pink color. You're unmasking that vascularity. That's very common. You'll start to probably notice that more. Okay, now let's close the melasma discussion and move into a different discussion. And before I do that, I just want to make a brief comment about glutathione. And I would really love for us to have a discussion about this if we have time. Glutathione is being used in many parts of the world and being given intravenously, IV glutathione for skin lightening. And let me just say that IV glutathione has never been shown to be effective for skin bleaching, for skin lightening, or any skin disease improvement in pigmentary diseases. What it has been shown to do is cause renal failure, Stevens-Johnson syndrome, sepsis, and death. And that's been reported in many countries, particularly in the Philippines and in Southeast Asia, where there is quite a bit of use of IV glutathione at med spas and in physician offices for skin lightening. This happens to be an article from the New York Times that I was interviewed for. It's even being done here in the US. This is someone in Manhattan, on the Upper East Side of Manhattan. You can see the IV bag is hanging in the background. This person's going in wanting to become fairer and lighter. And what did we talk about at the beginning? We talked about this concept of colorism and skin tone and skin color being related to patients' own identity. People want this, and they're going to ask you about it. We need to set the record straight that glutathione has never been shown to be safe and effective in an IV formulation for skin lightening. In fact, the FDA in the Philippines has banned it. The FDA here in the US has an advisory against it. So keep this in mind. I think this is really important for us as experts and you all as residents in training to help set the record straight until we have data to show safety and efficacy. Okay, now let's move into briefly a quick discussion about these conditions. And I'll give you a minute to give me your differential diagnosis in your head on what this is. Many of you probably already know this. When I show this to residents in the US, it's really interesting, especially if they don't see a lot of skin of color. This brings up lots of answers in the DDX. But if you answered that this is an example of Lichen planus pigmentosis, you're absolutely right. But I want to have a brief discussion about the differentiation of these various terms. So ashidermatosis, erythema dyschromicum perstans, lichen planus pigmentosis, idiopathic eruptive macular pigmentation, all these long fancy words that dermatologists love to create. What is the difference in between all of these things? And is there one? Well, this was a consensus paper that was published a few years ago that we worked on to really find out the differences between these various reticulated pigmentary disorders. So let me just say that within the world of these conditions, I do think there are some nuances that help us to understand the differences between what name you want to give these conditions. So let's start briefly by talking about erythema dyschromicum perstans and ashidermatosis. Those two terms can be interchangeably used, in my opinion. That term should be used exclusively for patients who present with large hyperpigmented macules and patches. We're talking 3, 4, 5 centimeter size lesions that typically start on the trunk and spread from the upper trunk downward. This typically does not happen on the face, neck, and arms. And this tends to be a condition that if you catch it early, you may see a little bit of redness or pink around the periphery of the patch. If you catch it really early, which by the way, I've seen tons of these cases and I've never really caught one early, maybe 1 or 2 cases that I'm like, I could convince myself had a little erythema. It can, in the early phases, almost mimic a fixed drug eruption without being indurated and swollen. It's flat, it's patchy, it's macular, but EDP and ashidermatosis is the term you should use when you see large areas of this on the trunk typically. Whereas lichen planus pigmentosis should be the term used when you see the acquired smaller 1 centimeter, less than a centimeter size hyperpigmented macules and patches. Typically, remember, we talked about on the lateral parts of the face, then moving into the central forehead, the lateral neck, and the axilla. Then it spreads downwards. But when LPP starts in its classic form, it tends to start lateral temples, neck, axilla. Those are the most common places, whereas EDP is larger and more trunkal. And why is this important? So, by the way, this is an example of one of my patients. As you know, I treat almost exclusively, I have a very high skin of color population in my clinic for obvious reasons. This is an example of which condition? This is lichen planus pigmentosis, right? We talked about smaller areas coalescing, axillary. This is LPP. What is this? Also, lateral neck. This is lichen planus pigmentosis. And why is this important? Well, this is important because one of the go-to treatments now for lichen planus pigmentosis is low-dose isotretinoin. And our colleagues in India have done an amazing job of this. Devinder Prasad's group has probably published the most on this. Low-dose isotretinoin therapy, 20 milligrams a day for 6 to 8 months in combination with photoprotection and antioxidants has shown to be very, very effective in many patients with lichen planus pigmentosis. Not all of these patients, but in many. So I used to use a lot of hydroxychloroquine, sometimes even clofazimine. Now I use almost exclusively, I try to get these patients on low-dose isotretinoin if I can, and we hopefully can see some improvement. Let me just make one other comment about the name lichen planus pigmentosis. In my opinion, it's not a great name for the condition because it is extremely rare to see lichen planus pigmentosis that had preceding lichen planus lesions. So patients who have classic lichen planus on their wrists, on their trunk, on their genitalia, wherever, those polygonal purple papules, lichen planus. When that lichen planus goes away, especially in patients of color, you know it leaves behind marks. That should be appropriately called lichen planus with post-inflammatory hyperpigmentation. That should not be called lichen planus pigmentosis, because in lichen planus pigmentosis on the temples, neck, axilla, you don't see preceding lichenoid lesions. So we don't know why this happens as a disease, still being thought to potentially be due to some epitope spread, potentially lead or heavy metal related. We don't know. But don't get these terms confused. And I hope that helps you delineate that a little bit more. Now, in the last few minutes before we take Q&A, let me make some brief comments about vitiligo. So we've talked about melasma and PIH. We've talked about ashy dermatosis and erythema dyschromicum perstans. We've talked about lichen planus pigmentosis, glutathione. Now let's finish on the opposite end of the spectrum with vitiligo. And I think you will all agree that vitiligo has very devastating psychological impacts for both the patient and families, particularly in communities of color. And that's why I think we need to make sure that no matter what we do with any patient with vitiligo, we give them hope, because there is hope for our patients with vitiligo. It's not just a disease now that we as dermatologists should say, here's a topical steroid prescription of clobetasol, I'll see you in 6 months. That really is doing a disservice to our patient. There are lots of newer therapies on the horizon. This is a very exciting time for vitiligo, and I'll briefly mention that. Before I talk about that, let me briefly also give you my definition of how to classify a patient who has active unstable vitiligo. If you have a patient who has active unstable vitiligo, you must do your best to stabilize this patient's disease, because if not, that patient's depigmentation is going to continue to spread, and they're going to turn into chronic vitiligo patients, which are the most common type we see, where the disease is there, they've had it for about a year, it's not getting better. Active unstable vitiligo is something that I try to assess and get a sense of on every vitiligo consultation. The way you try to define this is ask the patient, how much of new white patches or new light patches are you seeing develop in your skin in the past 4 to 6 weeks? And if the patient starts to tell you, I'm having a patch here, I'm having a patch here, it's here, it's here, I'm noticing new areas show up. Look at the patient's palm of their hand, which is obviously 1% of their own body surface area, And if they have more patches than 1 to 2% of their body surface area, they have 1 to 2% of their own BSA new patches within a 4 to 6 week period, they are active and unstable, and you need to stabilize them. That's a rough way to at least classify these patients. So how do you stabilize a patient? Well, you stabilize a patient by using your topicals, phototherapy, your antioxidants. But the other thing you do to stabilize vitiligo is oral mini pulse systemic steroids. Now, when I started getting involved in vitiligo and worked with my dear friend Pearl Grimes many, many years ago, we were doing intramuscular triamcinolone 60 milligram injections once a month for 3 months to calm down the disease, to shut down those CD8 T cells from attacking the melanocytes. I don't do that as much anymore. What I do now is oral mini pulse treatment. Again, a trick I learned from our colleagues in Asia, which is dexamethasone 4 milligrams, taking 1 tablet on Saturday and 1 on Sunday. And you give the patient 16 in 1 prescription. They take it for 8 weekends. So Saturday, Sunday, Saturday, Sunday, Saturday, Sunday, so on and so forth. And this is very, very helpful in stabilizing patients. So this is one of my patients with skin of color. Now, why do you know, by the way, why do you know this patient is active and unstable before you even ask them about their BSA or their POM of their involvement? The reason you know this person is active and unstable is because you can see the medial cheek. Does everyone see that hypopigmented patch on the patient's medial cheek? That is a reminder to all of us that vitiligo just doesn't turn white and depigmented overnight. In order to get there, it has to be hypopigmented first. So if you're seeing a patient with an hypopigmented area, that is unstable. And this is the patient after 4 weekends worth of oral mini pulse therapy. And what you can see, does everyone see the small little pigment islands starting to come in? Compare her neck. Do you see how it's slowly already getting better? Imagine how excited and hopeful this patient is going to be that they're already starting to see improvements because you're stabilizing their disease. So again, to recap for stabilization, find out how much involvement they're having, how much they're spreading with their own BSA. You could do intramuscular triamcinolone 60 milligrams once a month for 3 months, or do the oral mini pulse and counsel them to be on calcium and vitamin D. By the way, dexamethasone has less HPA axis suppression than does prednisone. So we get into less trouble with systemic steroids with dexamethasone compared to prednisone. I think, and that's an important pearl to know. Now, let me briefly mention antioxidants because we talked about polypodium leukotomas with melasma. Well, guess what? You can also give polypodium leukotomas to your patients with vitiligo. It's fascinating because there have been studies that have shown that patients on narrowband UVB phototherapy who are on polypodium leukotomas have higher rates of head and neck repigmentation compared to those who are on phototherapy without polypodium leukotomas. So not only do I recommend this for my melasma patients for their UV protection, I recommend it for my vitiligo patients as an antioxidant, and we are seeing improvement. I do also recommend an additional supplement for my vitiligo patients, which is a supplement that contains alpha lipoic acid combined with vitamin E and vitamin C. So for example, I'll tell the patient, take one of these in the morning, take a polypodium in the morning and another polypodium at night. And this has also been shown to be helpful when treating patients with phototherapy and higher rates of repigmentation. So antioxidants are something I use for virtually all of my vitiligo patients. Now, in the final word on vitiligo, on the new and exciting things that are happening in vitiligo, that's related to the Janus kinase inhibitor drugs, or the JAK inhibitors. Hopefully all of you have at least heard a little bit about this. They're not yet approved for vitiligo. We're one of the sites doing a lot of these clinical trials, and there's some exciting things happening. I'll briefly mention the 2 JAK inhibitors that I do use off-label for my vitiligo patients. One is tofacitinib, and the other one is ruxolitinib. Tofacitinib can be dosed orally, typically 5 milligrams every other day. It is off-label. You do have to monitor blood work, but in this study that was done by Craiglow and King's group, you can see a beautiful result in the hands getting better. And why is this study so exciting? There's been a lot of studies on this, by the way, since this one came out, but I love this one because what is the hardest part of the body to treat with vitiligo? It's the hands. I can do a pretty good job of getting patients' face and necks better, but getting their hands better is a whole nother challenge. And so to see that JAK inhibitors are now even giving us improvement in acral disease, I think is very promising. The other thing that I use frequently is Ruxolitinib cream. 1.5% Ruxolitinib topical cream used twice daily has been shown to be effective. We're doing a study on that now. We're involved in the phase 3 clinical trials. This was a nice study that was published by Rosemarin's group that shows nice rates of repigmentation in facial vitiligo. In fact, let me show you a close-up. This is baseline of this Asian patient. And just in 4 weeks, can everyone see the peri-oral area already getting the color back? I mean, really amazing results to see that. And remember, facial vitiligo is an area where we really can have an impact and help these patients. So I do use off-label JAK inhibitors frequently in my topical therapeutic armamentarium. And the final message on JAK inhibitors is that you do need concomitant phototherapy and light exposure for these to be optimal. So JAK inhibitors are not going to likely be the drug that is a monotherapy, one-stop fix for all of our vitiligo patients, but combine it with phototherapy and we can probably see really nice results. So you do need phototherapy to really help these work optimally, and that's what I do in my practice right now. More studies to come, but it's an exciting time, and I want you to leave this session at least giving your patients some hope that there are things on the horizon for vitiligo. Last few pictures on vitiligo. How do you know that this is unstable? Does anyone know what this is called? If you see this form of vitiligo, how do you know that this is unstable? Well, this is an example of confetti-like depigmentation. This was published here at Southwestern with our group. This is a sign of rapidly progressing vitiligo. Does everyone see the confetti or the little dot-like pattern? If you see this, you don't even have to ask them how much body surface area. Unstable, oral mini pulse therapy, systemic steroids stabilize their disease. Here's again another example of confetti. Does everyone see that very patchy confetti look? Stabilize these patients. You're doing them a disservice if you don't. This is another example of active unstable vitiligo. Does anyone know what this is called? This is called trichrome vitiligo. Trichrome vitiligo, meaning 3 colors, describes varying zones of pigmentation. So let me go back to the picture. So trichrome, you've got 3 zones. On the right, you have your normal skin. On your left, you have the depigmented. And then in the middle, you have this lighter zone, trichrome or 3 colors. The important thing about this is also a patient who needs active stabilization. If you look at that trichrome area, if you biopsy right in the middle, guess what you're going to see? You're going to talk to your dermatopathologist and you're going to see lots of CD8 mediated T cells right there. Because similar to, let's say, alopecia areata, where your patch of hair loss spreads outward and gets bigger because those T cells attack the follicles at the periphery, similar things happen in trichrome vitiligo. The T cells are at the edge. That's where you need to stop the disease from progressing. So stabilize these patients. So in the final minute of the talk, just to bring us back to where we started in talking about the issues related to fairness and skin beauty and skin lightening and colorism, I'm always fascinated when I travel around the world, which obviously none of us are doing right now. But when I go for different conferences and meetings, I'm always fascinated by what I see. So these are some pictures that I took. This is an example of a product that I found in India, which was a over-the-counter product that promotes fairness. And imagine the message we're sending to our patients and the public by telling patients that they can use something like this to lighten their skin. This is an example of a billboard that I took a quick picture of from a taxi on the way to the airport in New Delhi that talks about a product called Fair and Lovely that's been out for many, many, many years, multi-billion-dollar product that sells in India, claiming that they can be getting fair and lovely and make these women look more beautiful with fair skin. And this is not just exclusively in women, by the way. They also have products like this in many parts of the world that say, oh, you're a guy, you can become fair and handsome. Look at how great this product is going to make you look. This is also found in Southeast Asia and is now being, you can, by the way, find many of these things now in the US as well at ethnic food stores. Many of these things, by the way, contain topical steroids, arsenic and mercury, very, very toxic and dangerous. Speaking of which, I thought this article from the New York Times was interesting. Many countries in the world are now cracking down on skin bleaching products that are available over the counter. Particularly in Africa, Rwanda has taken a lead on this in cracking down on mercury and arsenic containing skin lightening products. Nigeria, we know, has a real problem with this. We see this in the US. I see patients of mine buying things online. And this is something we need to talk about. We need to have the discussion about safety, and we need to make sure we're not promoting these dangerous skin lightening trends. And the other thing we need to do is dispel myths from people on social media. Now, this is not someone I know. I have no conflicts of interest. I'm not certainly saying anything to attack this person, but this is someone on Instagram who had 7.5 million views on this video. This person, if you go to Instagram, I think now has 8 million followers and posts do-it-yourself skin lightening tricks, masks, how to make your hair brighter, all of these things online. And then you have 8 million people watching it. So imagine the amount of advice our patients are getting from social media influencers who are not board certified dermatologists, who've never done studies or research, but yeah, that's where our patients are going for advice. So we need to continue this dialogue in pigmentary disease and in skin of color so that we sort of show our patients what's safe and what's effective. So in closing, I hope this has been helpful to talk about topical therapies, give you some important pearls on the physical finding distinctions between melasma and lichen planus pigmentosis. We talked about tranexamic acid. We talked about off-label uses of second-line topicals, the chronic nature of melasma, JAK inhibitors for vitiligo, and really hopefully some clinical pearls that you'll be able to use in your training and beyond. If you're interested in getting more involved in Skin of Color, I always encourage residents in training to get involved with the Skin of Color Society at skinofcolorsociety.org. This is the largest international group dedicated to skin of color dermatology. My conflict of interest is that I'm the immediate past president of this group. We now have over 1,500 member physicians from 49 countries around the world. There are resident research grant and mentorship opportunities available. So please feel free to download some of those free materials. And there are also free patient education handouts in both English and Spanish for the most common skin of color diseases. It's been my honor and privilege to be with you all today from wherever you're tuning in from around the world. Please feel free to reach out on social media, on Twitter or Instagram or via email. And I look forward to seeing you all in person very soon. Thank you.
Thank you so much, Dr. Desai. I'm just going to read some of the questions that people had posted in the chat box. So the first question was, once determined to have melasma responsive to tranexamic acid, do you continue at the 325 milligram 12-hourly dose or wean/stop?
Thanks, Akash. That's a great question. So I used to do, patient got better on twice daily. They've been on it 3 months. They're doing well. Let's taper down to once a day, try to wean them off. Honestly, it doesn't work that well, and I'll tell you why. Tranexamic acid has a pretty short half-life. The half-life is only about 7 hours, hence the BID dosing. And so I don't do any tapering. What I do is if they're getting better and they're on it and they're happy, I'll continue the patients on it for up to 6 months. If they really have recalcitrant disease, I'll even continue it longer. I have a couple of patients on it over a year, and then I'll just try to stop it completely on its own. I will tell you that once patients are on it and it works, it's hard to get them off of it because they're so petrified that their melasma is going to come back because they've responded so well. So that's another discussion, but then I usually transition them to the 3% topical tranexamic.
Great, thank you. The next question we had was, what's your first-line treatment in lichen planus pigmentosis?
So my first-line treatment in lichen planus pigmentosis is to get a good biopsy and to talk with my dermatopathologist to find out how much inflammation is happening in the skin. If there is a dense lymphocytic infiltrate still in the upper parts of the dermis, I will blast these patients with a prednisone taper to really calm it down, to hope that the pigmentation will not perpetuate. So biopsy, find out how much inflammation, systemic steroids to put out the fire, and then I transition them to topical lightening agents with triple combination therapy the oral antioxidants, sunscreen, and then low-dose isotretinoin. That's kind of how I would approach it.
Great, thank you for that. And then another question we had was, can you please tell us again how to differentiate between melasma from other pigmented disease?
Sure. So yes, the most common four things on the face that people tend to confuse melasma with: facial acanthosis nigricans, lichen planus pigmentosis, periorbital hyperpigmentation, melasma. Those are the four most common. So a couple of quick reminders. Lichen planus pigmentosis, when it happens on the face, tends to start on the lateral temples down to the preauricular area and then spread to medial forehead. Melasma tends to be more medial, bilateral cheek, chin, upper lip, sometimes the glabella and central forehead area. Tends to spare nasolabial fold. Within the patch of melasma, you will see that peaking sign often, which is the normal skin peeking through. Facial acanthosis nigricans tends to be more preauricular on the cheek, then extending medially, whereas melasma is more medial, extending laterally. Facial acanthosis nigricans also, by the way, sometimes can have a texture to it, not as velvety and acanthotic as neck or axillary disease. But on the face, if you really touch and palpate, you can sometimes feel that. It almost looks a little rough in texture, not always, but it can. And then peri-orbital hyperpigmentation, obviously around the orbit, spares 1 to 2 millimeters below the brow. So let's say you have someone who has hyperpigmentation in the whole orbital area, involves the entire eyebrow. That's probably something else, like post-inflammatory hyperpigmentation from a photoallergic or photocontact dermatitis. Classic periorbital hyperpigmentation spares 1 to 2 millimeters below the brow. You'll see a normal skin sparing. And we can probably talk about that more on another talk.
Okay, great. Another question we had was concerning melasma. You mentioned that thyroid dysfunction may be associated with the disease. So if you have treated the diseases with no improvement, you have to think of thyroid involvement. Wanted to know how long you have to treat before you can think of investigating on the thyroid.
Yeah, that's a good question. And I don't have a straight answer for that. But what I will tell you is that if I have a patient who I've put on that 12 to 16 week phase 1 of rotation with the triple combination, with the hydroquinone and the lightening, and then they're not better at all, well, maybe I'll use the triple combination a little bit longer. Then I'll try second line topicals. Then I may even move into chemical peels. But when you use that 12 to 16 weeks and it's not budging at all, there's no movement, and then you still try second line topicals for an additional 6 to 8 weeks, let's say, then you need to start thinking about, okay, do I need to maybe even do a biopsy, see how deep this pigment is? Because remember, if it's deep down in the dermis, topicals are probably not going to help. So that's when I would make the decision to check some blood work, do a biopsy, a little bit more further investigation. And by the way, doing a 2 millimeter punch biopsy kind of laterally on the cheek, everyone's mortified to do biopsies on the face because of scarring. A 2 millimeter punch biopsy usually heals very well in most patients. And if you have a patient who's not responding, you have to have that discussion that I need to get some more data on your disease, because eventually they're going to keep using topicals. And if the pigment's deep down in the reticular dermis, no point in them doing that. Then you need to think about oral tranexamic or peels and maybe even laser.
All right, thank you. And the next question is, what would be your opinion on the pulse therapy used for unstable vitiligo in pediatric patients?
Yes. So I do use the oral mini pulse to stabilize my pediatric patients. Let's say you have someone who's 13 years old or 12 years old. You can half the dose of the dexamethasone. So instead of doing 4 milligrams on Saturday and Sunday, you can do 2 milligrams on Saturday and Sunday. And you can do this as well. Typically in that case, I'll do it for 4 weekends instead of 8. And I do have a conversation with the pediatrician just to make sure that we're on the same page about that. But yes, if you have a patient below the age of 16, 12-year-old, 11-year-old, 13-year-old, you can half the dose to 2 milligrams and try it that way. And by the way, just keep in mind that stabilizing with oral mini pulse does not mean you do not start phototherapy and topicals. I mean, again, combination disease approach. This is not a monotherapy. If it's active and unstable, you have to attack it fast to calm it down. So I'm going to put them in the light box. I'm going to put them on oral mini pulse. I'm going to do the alpha lipoic and the polypodium. I'm going to give them topicals, maybe even the topical JAK inhibitor. I'm going to do all of it to get it calmed down as fast as I can.
Okay, and I believe a follow-up question to that was, should the dose of dexamethasone be tapered before stopping the pulse therapy?
No, I usually do not taper it. It's 4 milligrams on Saturday, Sunday. I give it for 8 weeks. And then I say, come back for, I'll follow you in the meantime, especially if they're on phototherapy. I usually see them at least once a month just to kind of eyeball the patient, see how they're doing. And then I won't taper it. No.
Okay, and I think our final question is, how do you approach treatment of periorbital melanosis and acanthosis nigricans in addition to advising patients to lose weight for the latter?
Well, that's tough. Peri-orbital hyperpigmentation is tough. I'll give you two pearls that I use. I do use the lightening agents. I do use hydroquinone very, very cautiously. And you have to be careful to use it around the eyes because the eyelid skin is more sensitive, but I do use it. I also use chemical peels very frequently for my patients with periorbital hyperpigmentation and facial acanthosis nigricans. Lactic acid chemical peels have been shown to be helpful in the periorbital area. You can get them in a gel formulation, so they're a little bit thicker, and that way they don't run like a liquid and risk getting in the eye. The other thing that I have found helpful for periorbital hyperpigmentation, particularly for the infraorbital dark circles, is very shallow depth microneedling, 0.5 millimeters, and then you combine that with a 10% TCA peel. So you do the microneedling, and in the same session, you do 10% TCA applied after the microneedling, and you do one session a month. Our colleagues in Greece and in the Middle East actually have published the most about this. Some really nice papers on PubMed if you're interested.
Great, and I think there's just one more question somebody just asked, if we have time. Just given the efficacy of JAK inhibitors and mechanism of action, do you use these in active vitiligo or in chronic settings?
Both. I use them in both. And it is off label, but I have found them to be helpful. And a lot of times in my topical use of the Ruxolitinib 1.5% cream or the Tofacitinib 2% cream, what I will do is use that as the monotherapy topical instead of using a steroid and a calcineurin inhibitor like I used to do. So I have found that the topical JAK inhibitors, from a compliance perspective for the patient, are more helpful.
Great, thank you so much for answering all those questions. I think that was it in terms of
Great
questions.
questions.
I'm going to pass it on to Crystal now just for the closing remarks.
Thank you so much, Dr. Desai, for such an excellent presentation. And thank you all of our attendees from across the world coming. I see we have those from South Africa, Spain, UK, Argentina, Philippines, Nepal, Israel, Tanzania, places from all over the US. Thank you so much. Before you all leave, please fill out our feedback form, and that's just to let us know how we're doing and different ways and how we can reach you all in better. Also, before everyone leaves, we would like to do a photo of everyone. So